This conference will now be recorded.
So today's talk article, this is from the July 2020 talk and on WHO type 1 on ovulation. Okay, so first we'll be discussing the talk article and then we can do the CPD questions to revise our knowledge, how far we have gained from this talk article. Okay, so this is predominantly the WHO classification for the disorders. We know that already from our previous knowledge of infertility that there are three classes of anovulation. Anovulation means ovulatory dysfunction. There is ovulation is not happening. So this is one. Anovulation is one of the commonest cause of the infertility after the male infertility pattern. So we have to now see that this is type 1, type 2 and type 3. Type 1 is women with primary or secondary amenorrhea whose low levels of endogenous gonadotrophins and negligible endogenous estrogen activity. So basically, we classify these categories according to the amount of gonadotrophins. So type 1 is like you have hypogonadism and hypoestrogenism. So you have both the things low, that is low levels of gonadotrophins along with the low levels of estrogen. Okay, so here if you remember, then this is the way how it goes, that there is the hypothalamus, then the pituitary, and then are the ovaries. So the stimulus from the GnRH pulses. So hypothalamus has the GnRH, it releases the GnRH in a pulsatile pattern, and that causes the release of the FSH and LH from the pituitary. So on an average, the pulses occur at the rate of the 90 minutes in the follicular phase, and in the luteal phase, it occurs every 3 hours. So it is different. Therefore, the amount of the FSH and LH produced also varies. So accordingly, in the follicular phase, the pulses are in every 90 minutes, while in the luteal phase, the pulses are every 3 hours. So now this leads to the development of FSH and LH. So at the beginning of the menstrual cycle, the FSH is released from the pituitary, and that leads to the follicular development. And then maturing follicle, when it produces the estrogen, that estrogen has a negative feedback on the hypothalamus. So this is the normal mechanism happening. Now, what is the problem? If any problem is there in hypothalamus and pituitary, then the gonadotropins are less. And since the gonadotropins are produced in lower quantity, so estrogen is also not produced. So overall, there is hypogonadism with hypoestrogenism. So this is type 1. Okay. In type 3, the defect is here at the level of the ovary. It's the premature ovarian failure type of thing. So estrogen is not produced. So this negative feedback does not happen, and so the FSH and LH increases. So type 3 is hypergonadotropic but hypoestrogenic. So this is type 3. And type 2 is other PCOS types of disorders in which usually you find the normogonadotropic, normoestrogenic. So accordingly, we have three classes. So these are type 1 with low gonadotropins and low estrogens. Type 2 is variety of menstrual disorders who exhibit normal endogenous estrogen and gonadotropin range, while in type 3 we have low endogenous estrogen but high gonadotropins. So you see in 3 there is a difference in the level of gonadotropins. So type 1 you have low levels of gonadotropins. Type 2 you have almost normal level of gonadotropins. Type 3 is you have high level of gonadotropins. And suppose now you have understood what is the mechanism behind every one. So this is 3 types. So predominantly we'll focus our discussion now onwards on this type 1 anovulation. If anything is not clear, please let me know in between. I'll repeat it again. Now the WHO type 1 anovulation, we now know that it is predominantly because of either the causes at the hypothalamus or the pituitary. So basically these are classified into the three, that is hypogonadotropic hypogonadism, HH. From this, they have separated the two different categories in which the hypothalamic amenorrhea is a one category which is predominantly because of the hypothalamic causes, and hypopituitarism, which is because of the organic causes of the pituitary. So these two categories, although there is a overlap because this includes both of these things also, but these two categories have been separated. So we'll just now go through one after other, all the three categories. What are the different presentations we can see in these? So now we will focus on the anovulation type 1 in under these three categories. So first, the general thing. What is the physiological role of hypothalamo-pituitary ovarian axis? I just mentioned that there are GnRH pulses which lead to stimulation of FSH and LH from the pituitary, and finally these FSH and LH stimulates the ovaries to produce the estrogens, and the estrogen feedback goes to the hypothalamus and pituitary. So this is the normal hypothalamo-pituitary ovarian axis, how it works. Now what happens at the time beginning of the menstrual cycle? If you see from the beginning, then this FSH level keeps on rising and rising. So at this time follicles are recruited, and this leads to the formation of mature follicle. Now, once the mature follicle produces the estrogen, so now you see the estrogen level is rising high. Once the follicle matures, this is at the highest point. So, it predominant estrogen at this point is the 17 beta estradiol, which exerts the negative feedback now to decrease the further release of the FSH. So now the FSH becomes low. And at the same time, there is a positive feedback effect which leads to LH surge. So you have FSH decreasing, but you have LH surge which leads to the ovulation. So at the time of the LH surge during the periovulatory period, both the amplitude and the frequency of the GnRH pulses now decreased. And this leads to the rupture of the follicle, and then there is release of the oocyte. Now the predominant hormone in the luteal phase is the LH. So LH and the progesterone. Under this effect of LH, the granulosa cells undergo differentiation to produce the lutein cells, and so the progesterone is produced by those lutein cells. So this is how the normal hypothalamo-pituitary ovarian axis works in the women menstrual cycle. Now, this is the two-cell theory. That is, there are two types of cells, theca cells and the granulosa cells. So, this is the theory which is responsible for the formation of the estrogen. So, estrogen synthesis in the ovarian follicle requires the presence of both cells, the theca cells and the granulosa cell, and this is known as two-cell, two-gonadotropin theory. The theca cells of the follicle secrete the androgen. So you can see here that the substance produced, the final substrate produced is the androgen. And this androgen requires the E450 aromatase enzyme to get converted in the estradiol. But theca cells do not have this enzyme, so they are not able to convert this into the estradiol. So this androgen has to cross the basement membrane, and this enzyme is present in the granulosa cells. So the final 17 beta estradiol is produced in the granulosa cells. And now how it is, the FSH, as the FSH level rises, it causes the enzyme activity which leads to activation of P450. You can very well clearly see the effect of the FSH through the CAMP pathway, activating the protein kinase A, and finally activating the P450 aromatase, which leads to the formation of the 17 beta estradiol. So this is sorry. So this is how the FSH causes the release of this. So this is how the two-cell theory works. So LH also affects the endocrine activity of these cells. As you see, the LH receptors are present on the theca cells. So initially, this progesterone produced by the theca, the lutein cells will actually take over, and they will provide the nutrition up to by the time the placenta takes over. Now, with adding to more confusion, we have the neurotransmitters which act at the level of the GnRH neurons. So, the important neurotransmitter at this level is the kisspeptin. This is an endogenous ligand for the kisspeptin receptor, which is a product of the human KISI gene. So it is an important, it has multiple effects on the GnRH neuron. Predominantly, it causes stimulation, and this is required for the puberty onset and maintenance of the normal reproductive function. Whenever there are KISI gene mutations, that leads to disrupted pathway, and there is amenorrhea and hypogonadotropism is there. So basically, kisspeptin stimulates the secretion of LH and FSH through the GnRH neurons. And amongst the FSH and LH, it has more activity on the LH, this luteinizing hormone pathway. So the this same feedback, most important feedback, which is responsible for carrying out the control of the activity, still remains the estradiol. So 17 beta estradiol is the main negative influence which puts a check on this cycle. So 17 beta estradiol is the most important positive or the negative feedback which is required by the HPO axis. HPO axis. The other important regulatory protein is the leptin. So now we know that one is the kisspeptin and the other is the leptin. So leptin is produced in the adipose tissue and it acts as a satiety signal to the brain. The presence of the leptin is important. Because it also acts on the GnRH stroma and the other areas with the kisspeptin neuron, and has its effect on the production of GnRH and FSH. And it is also required to be present at a certain amount for the proper initiation of puberty. So kisspeptin and the leptin are two important ones which are required in adequate amounts for the proper functioning of this GnRH and the pituitary pathway. Why this is important? Because the kisspeptin and the leptin stimulating drugs are being tried to be used in the infertility treatments with this type 1 anovulation. Although they are still in research trials and not used now, but because this is being happening, so we should know that what is the role of these neurotransmitters. Now we come to the various causes, that is the hypogonadotropic hypogonadism in general, under three categories. So hypogonadotropic hypogonadism, this is hypothalamic amenorrhea, and this is hypopituitarism. So in this hypogonadotropic hypogonadism, as the name signifies, we have hypogonadotropins, that is lower amount of gonadotropins. So in this case, FSH, LH is low, and in hypogonadism, that is the estrogen is also produced in lower amounts from the gonads. So there is lesser amount of estrogen also. So what is the definition of this hypogonadotropic hypogonadism is? It results from the complete or the absence of GnRH induced LH and FSH secretion. So basically, it is the complete absence or partial absence of GnRH induced LH and FSH secretion. The causes which originate in the pituitary have been given a special place. It's a different this category. It is not included in this. So these patients, the congenital or the idiopathic hypogonadotropic hypogonadism is the predominant one seen here. And there is another category which is idiopathic also. Now the Kalaman syndrome is one important cause, and we need to know the few things about the Kalaman syndrome. It is a variant which is characterized by the anosmia or the hyposmia, and it is basically there is a defect in the migration of the neurons, GnRH neurons from the nasal placard to the hypothalamus. So because of this migration defect, there is this syndrome, and there are other associated midline problems also. The midline craniofacial defects also. So along with that, renal agenesis, aplasia, and dental defects are also there. Now, in the KISI mutations, it is because of there is inadequate functioning of the KISI gene. So kisspeptin is overall decreased. And since it's a stimulating pathway, so that if it is not working, there will be deficiency of the gonadotropin hormones. The other diseases like infiltrative disorders such as hemochromatosis, sarcoidosis, vaginous granulomatosis, and histiocytosis. Some drugs such as glucocorticoids and narcotics. How do glucocorticoids work? Same is the phenomena. How does stress work? Because even stress or the glucocorticoids, they will produce more of corticosteroids. So that will lead to these will lead to the increase of the CRH from the pituitary, and that leads to the deficiency, negative feedback on the production of other hormones like FSH and LH. So that is why the stress or the presence of glucocorticoids, they will have a negative feedback on the pituitary to produce the less amount of the gonadotropins, or they will have a negative feedback in fact on the hypothalamus. So overall the GnRH is also produced less. So that is why stress induced amenorrhea is there, and same is the mechanism with the glucocorticoid induced amenorrhea. So infections such as meningitis, encephalitis, or tuberculosis, or any type of trauma or space occupying lesions can be there. So now how do these patients actually present? So if you see biochemically, in these patients, the FSH is low, LH is low, estradiol is low, AMH can be normal or low. Ovaries are usually small and multicystic because small antral follicles 2 to 4 mm are present there, which are inactive because for further growth they need the presence of the FSH, and because FSH is not adequate, so they cannot grow into the dominant follicle. So you can get small multicystic. Usually there are small ovaries, and with small antral follicles present, no antral follicle is usually growing. Uterus is small, endometrium is thin, body weight may be normal or high, and period pattern is usually primary amenorrhea. So it is from the beginning the patient has the amenorrhea. So this is the typical clinical presentation of these patients. So this is how it works. Why it is important to know? Because when we will go to the management, we need to know what we have to give to this patient. Now we come to the next category, that is the hypothalamic amenorrhea. So these patients are predominantly, this is considered to be a neuroendocrine disorder. Okay, so it is caused by the low energy levels and the deficient leptin levels. So these, you can see, they are predominantly not the exactly hypothalamic causes, but they are other causes which are acting through the neuroendocrine axis, that is through the neurotransmitter level, and causing the effect on the hypothalamus. So in these cases, like the excessive exercise, eating disorders, nutritional deficits like the anorexia nervosa or bulimia nervosa, psychological stress, critical illness, chronic illness such as malabsorption syndromes like celiac disease and inflammatory bowel disease. So all these things, they will lead to the hypothalamic amenorrhea. They will rather be classified into the hypothalamic amenorrhea. So now in this case, you see that there is not much difference in the production of the GnRH or the FSH-LH. There are basically the other mechanisms which are leading to this amenorrhea, which are predominantly the problem with the neurotransmitters. So basically in this category, so there is FSH and LH, predominantly they are normal or towards the low normal. Estradiol is low. Antimalarial hormone can have any value, low, normal, or high. Similarly, the ovaries will be small with small antral follicles present. Uterus is small, endometrium is thin because it is not growing, and body weight is low or lean. So these are basically more connected to low and lean body levels and associated low leptin levels, because leptin is from the adipose tissue. So these patients will have low leptin levels and they predominantly have the secondary amenorrhea because there is no defect in actually the GnRH and the gonadotropin pathway. So it was actually normal, but when these conditions intervened, then the patient became the amenorrheic. So hormone levels are still maintained at the upper level, that is the GnRH and FSH-LH, although the estrogen production is low, and these are lean patients with low leptin levels. So this is the characteristic clinical picture you can see in the hypothalamic amenorrhea. Ovaries, when you see multicystic, then you can get confused with the PCOS picture, because in this case also you see that this is normal or low normal or low normal. So this goes exactly with the PCOS, but what is different is that in PCOS the estradiol will be normal, but in this case the estradiol is low. So this is the way a lean patient with multicystic ovary, normal FSH-LH, how you will differentiate that patient from the PCOS. It is by the estradiol and maybe by the AMH, because in PCOS you can find the high AMH, but predominantly it is the estradiol which differs. So there is a overlap between this category and the PCOS category. So you can see here, this is normal or high. FSH-LH ratio may be altered in the PCOS. It is, remember, alteration of FSH-LH ratio, that is increase in LH, is not a diagnostic of PCOS. It is usually associated with the PCOS. It is not a characteristic feature, but it is usually associated. So it can be either normal or high. But you see the estradiol is normal and antimalarial hormone, it is high. And the ovaries, along with having cyst, will have a higher volume, which is not likely to be present in these patients. So to differentiate these two categories, it is important to know the estradiol levels. This is regarding the hypothalamic amenorrhea. Now comes our third category, that is the hypopituitarism. So what is happening in this category? There is a decreased secretion of the pituitary hormones. So it can be, the causes can be either the congenital or the acquired. So congenital causes may be associated with structural abnormalities of the pituitary gland, including the aplasia or the hypoplasia of any lobe like inferior lobe, or there is a problem with the posterior lobe or absence of the stalk, or there are common acquired conditions like there is infection, inflammation, trauma, infiltration, all these tumors, and these conditions can be there. So now this is because these gonadotropins are not produced in adequate amounts from the pituitary. So the how you will see this biochemical picture. So FSH is low, LH is low, estradiol is low, AMH is low, ovaries are small, uterus is small, endometrium is thin. Body weight does not carry any significance according to this, and primary or secondary amenorrhea, any type of picture can be there depending on what is the cause. So overall, these patients will have everything low, small ovaries, uterus also small, and thin endometrium. So these are the patients with this type of picture. Now, how about the management? So as we know, because the patient is amenorrheic, she is having low gonadotropin levels. So we have three main things to address. One is the patient's bone growth, development of puberty. Once the puberty is achieved, then we have to take care of bone growth and the heart problems, cardiac problems. So these are the main things we have to look on. And the next most important thing is if patient wants fertility. So overall, this is hypogonadotropic state. So we need to add the hormones to the patient's management. Now, how to manage these patients? These patients need the multidisciplinary approach. Input is usually required from the pediatricians, endocrinologists, reproductive medicine specialists, and the psychologists. So all these together work to devise the management plan for these patients. Hormone replacement therapy. Now, one thing is that if the patient is diagnosed before the puberty, she has not attained the puberty in any of these categories, then you have to start the estrogen. So once you initiate the therapy with the estrogen to induce the puberty at an age appropriate time, that is when you expect the normal puberty. So a few years, 1 or 2 years before that, you have to start the estrogen so that the patient mimics the normal puberty and optimizes the adequate height gain. Now, when is the progesterone added? Progesterone should be added to estrogen as part of hormone replacement therapy once breakthrough bleeding has occurred with estrogen alone. That means that enough endometrium has grown, then you need the progesterone. So you first have first 1 to 2 or 3 years, you need only estrogen, and then once there is a breakthrough bleeding, then you will give the progesterone in these patients if you diagnose before the puberty. Now, in the young women who already once have achieved the puberty and now they land up into the amenorrhea, then you have two options with you. One is the combined oral pills, or you can give the hormone replacement therapy. So combined oral pills usually have a estrogen component as ethinyl estradiol, which is a synthetic estrogen, and it is combined with the progesterone. Or so you can give these pills, or you can combine separate natural estrogen, that is 17 beta estradiol, and then add progesterone to it, which will be the HRT. So either COCs or HRT, you can use both the things. There is no clear evidence that whichever works well, but studies show that HRT works better than the COC. There is no clear recommendation as of now that you have to give COC or you have to give HRT, no clear recommendation. But in studies, it have shown that HRT gives a better results if you take into account the bone health. Now, management of low bone density. So in these cases, as I said, we need HRT, which is more effective than COCs for the bone health. So you will give here the transdermal natural estrogen therapy. That is, you can give the estrogen patches along with the cyclic oral progesterone. So this is the one which is recommended if you are particular about the low bone density. then you can use the estrogen therapy with the progesterones in the teenage girls and women who have not had return of menstruation after you have done your nutritional, psychological, or whatever cause you think. For the hypothalamic patients, first thing is to do the lifestyle management, because as you remember, if you go on to the hypothalamic amenorrhea causes, the causes were predominantly because of the stress, exercise, eating habits. So these are all lifestyle modifications. So first, for hypothalamic amenorrhea, the first thing you have to do is, if you have all these features, precipitating features, you have to work on the lifestyle modifications and the behavioral modifications, and then come the roles of various drugs. So if you are using in these patients for secondary amenorrhea, first work on those conditions. If after those conditions still the patient does not have the normal menstruation, then you need to add the estrogens and the progesterone. Now the biphosphonates or the denosumab, testosterone, or all these which are usually used in the patients with osteoporosis. So these are not recommended in these young girls as first line. So you have to, as first line, give the estrogen and the progesterone replacement. Now the second important thing is prevention of cardiovascular disease caused by the hypoestrogenism. So what actually hypoestrogenism do to these patients? It increases the total cholesterol and very low density lipoprotein cholesterol, low LDL, VLDL, LDL, total cholesterol, and triglycerides. So all the bad type of cholesterols, they increase. When there is a hypoestrogenism, there is increase in all the bad cholesterol. That is the total cholesterol, the VLDL, the LDL, and the triglycerides, along with the reduction of sex hormone binding globulin synthesis and release, which can adversely impact the cardiovascular health. So estradiol exerts a positive cardioprotective effect through its influence on endothelial, myocardial, and vascular function and metabolic parameters. So timely estrogen replacement has to be done to reduce the risk of ischemic heart disease and associated cardiovascular disease mortality associated with low estrogen levels in young women. So again comes the role of hormone replacement therapy. Now, lifestyle changes and non-pharmacological measures, they are predominantly important in hypothalamic amenorrhea patients. So the combination of reduced exercise, changing calorific intake so that minimal goal of 30 kilocalories per kg of lean body mass is achieved, so can help reverse hypothalamic suppression. So this has to be followed. And secondly, cognitive behavioral therapy or the psycho counseling, because there are multiple things which are associated with this. So stress, anorexia nervosa, bulimia, so these are all, they need the CBT. So lifestyle changing and the cognitive behavioral therapy. What is cognitive behavioral therapy? It is like a talking therapy, or it's like a counseling session wherever in which the constant positive feedback or the positive notes are actually given to the patient. So it is series of sessions. It's a psychological counseling. So it is known as cognitive behavioral therapy, and it is performed by the trained persons in these fields. Leptin therapy, because we have already studied that the low leptin levels are associated with hypothalamic amenorrhea. So giving the leptin can help. The hormonal measurements when seen after giving the leptin, they show that there is significant increase in the LH, FSH, estradiol, and the progesterone levels. And no major side effects has also been seen with this therapy, but still this therapy is still in a research trial. It is actually still in a research phase. So there is no such recommendation, or not, it is not used clinically. So this is the now only in the research trials. Fertility treatment. Now we have already covered the aspect of general health of the patient. That is for her attainment of puberty. Then secondly, her bone health, then her cardiovascular health. And now what is important is that if she wants the treatment for fertility, then what to do. So first thing before starting any fertility treatment is that patient's general health should be improved. That is, optimization of the body weight should be done, or if there is any chronic disease, that should be treated or managed appropriately. Fertility treatment can take the form of pulsatile gonadotropin stimulation of the pituitary gland, or you can directly give the exogenous gonadotropins, because all the action here in type 1 is happening at the hypothalamus and the pituitary. So two things can help us. Either we can give the GnRH, pulsatile GnRH stimulation, or we can directly give the gonadotropins, that is the FSH and the LH. So it is recommended that clinicians should only induce ovulation in women with the hypothalamic amenorrhea who have a BMI of at least 18.5, because this is the category in which you have lean thin patients, low peptide levels. So you have to see the weight should be more than 18.5, and only after that attempts to normalize energy balance as a means to optimize the health before pregnancy. And how will this affect the pregnancy? It will reduce the risk of fetal loss, small for gestational age babies, preterm labor, and delivery by cesarean section in underweight women. So these are the benefits if you first make the BMI correct. Minor adverse effects of the treatments include nausea, breast tenderness, and bruising at injection sites. With the average monthly chance of conception is about 20%, the same as natural conception, and it may take few months to achieve a pregnancy. Please don't confuse it with the IVF. Here we are only talking of ovulation induction by gonadotropins. We are not talking of IVF. They don't need IVF. We just have to do the ovulation induction. So we are talking of these percentages in term of ovulation induction. Okay. If the patient does not respond to, if the patient does not conceive with gonadotropins, that is, you are giving adequate gonadotropins, there is ovulation induction, still patient is not conceiving, then probably the IVF will come into action, but not at this point of time. We are just talking of ovulation induction. So with the average monthly chance of conception, it is about 20%, the same as natural conception. So once you make these patients ovulate, the chances of conception are equal to the normal conception, and it may take few months to achieve a pregnancy. Risk of multiple pregnancy in these patients is about 5 to 10%. And the endometrial thickness, which should be adequate, should be 7 millimeter. Because these have patients have low estrogen levels, so it is good to give the estrogen only for 2 to 3 cycles, so that you prime the endometrium and then you induce the ovulation. That way you can get the better results, because at least 7 mm of endometrial thickness is required to attain the pregnancy. Clomiphene citrate for the hypothalamic amenorrhea. Now, in hypothalamic amenorrhea, we know that there is normal gonadotropin levels. So, here the clomiphene citrate can also work. So, in patients who have values around normal, you can try the clomiphene citrate also. So, women with the hypothalamic amenorrhea who have normal or low normal gonadotropin levels, along with endogenous estrogen production, often respond to clomiphene citrate. But see, the main thing is that you have to have all of this normal. Always, whenever you are picking up this option of clomiphene in this hypothalamic amenorrhea, see the levels should be normal. Otherwise, it will not work. Women should therefore be offered this option before using gonadotropins. But remember, normal. Word normal for FSH, LH, and there should be endogenous estrogen also. Pulsatile GnRH treatment. This is suitable for the woman with an intact pituitary gland, especially for women with idiopathic hypogonadotropic hypoestrogenism and hypothalamic amenorrhea. So in this there is pituitary gland and the hypothalamus pituitary axis should be perfect. You are giving the GnRH, now it will go and act on the pituitary to produce the FSH and LH. Okay. In the previous one, when you are giving the gonadotropin, so you are directly giving the FSH and LH. So no need of pituitary to produce its own FSH LH. In this case, you need pituitary to be properly working. So how it is? The infusion of the GnRH is achieved by the way of the computerized pump at the pulse intervals of 60 to 180 minutes. So this is the way you can adjust with the best outcome of ovulation and pregnancy, which is seen at the 90 minutes, which is very near to the natural pulses. The GnRH may be administered by the intravenous, subcutaneous, intramuscular, nasal or sublingual routes, and the subcutaneous dose is usually 15. This is microgram. So 15 microgram is used to commence the treatment. Pulsatile GnRH treatment has a lower risk of multiple pregnancy than gonadotropin injections. GnRH has the advantage that it produces the monofollicular growth. So that is why there is less chances of multiple pregnancy. The main disadvantage is that there is the high cost and the need to attach a pump on the body. And in UK, presently the GnRH pumps are not available. But obviously this has a better role. So it gives a monofollicular growth. So there are low chances of multiple pregnancy, and even the cumulative pregnancy rates as seen with GnRH as compared to gonadotropins, GnRH has a better cumulative pregnancy rate. This is gonadotropin therapy. HMG is recommended because it has both FSH and LH, and we need both. So HMG is recommended for ovulation induction in women with type 1 anovulation, because stimulation with FSH alone in LH depleted women. If you are giving only FSH, then what is the problem? It leads to higher consumption of the gonadotropins, and there is still low follicular growth, reduced follicular growth, lower estradiol levels, and lower overall ovulation rates. The starting dose can be 75. If you already not know what is the FSH threshold, then 75 is the safest to start. 33% increments you can do, but you have to do the ultrasound monitoring of the follicle. Endometrial growth is considered a good biomarker for rising concentrations of estradiol. No need to do the serum estradiol monitoring. You don't have to do the serum estradiol monitoring. If you are having a good endometrial growth, that itself shows that the estradiol is produced in adequate amounts. Growth hormone, it does not have much role. It has only role in the patients who already have known growth hormone deficiency. So growth hormone may benefit women with hypopituitarism by improving the response and outcome of ovulation induction with HMG. The dose, if used for the co-treatment for ovulation induction, is 24 units on alternate days or 12 units daily. So it is used only when you know that there is a growth hormone deficiency. Luteal phase stimulation, although not clearly known, with progesterone is empirically offered. No recommended protocols is there, but it can be administered in the form of twice weekly HCG, or you can give daily vaginal micronized natural progesterone pessaries. So anything on this can be done. There are no clear recommendations for that, but it is actually empirically offered to all patients. Now, this finishes this talk article. So basically, to summarize, we initially studied there are three types of WHO: type 1, type 2, and type 3. Type 1 is low gonadotropins, type 2 is normal, and type 3 is high gonadotropins. So when we classify type 1, we have hypogonadotropic and these patients, and then we have hypothalamic amenorrhea, and then we have the these hypopituitarism. So we studied the various in how the biochemical things are there, FSH, LH, and everything. And finally, when we come to management, then there are gonadotropins or the GnRH you can use. First, you have to give the lifestyle modifications, and there is role of CBT also. Multidisciplinary team has to act for the treatment. And in otherwise patients were not for fertility but for the general well-being, you have to give the estrogen and progesterone replacement for initiation of puberty or the maintenance of the bone health and the cardiovascular health. So this is in crux about this important talk article. Now these are the CBT questions. So you will have to answer in true or false. So with regard to the WHO classification of ovulatory disorders, type 1 is characterized by the hypogonadotropic hypoestrogenic states. Is it true or false? Please answer.
True. True.
It's true. Yes, type 1 is hypogonadotropic hypoestrogenic. This is true. Gonadotropins are also low, estrogens are also low. In type 2, it includes the polycystic ovarian syndrome and premature ovarian failure. So it is true or
False.
false?
False.
Yes.
False. It
Because
is type 2 for polycystic, type 3 for premature ovarian failure.
yes, absolutely correct. In PCOS, this is type 2 and premature ovarian failure is type 3. Because in this case, estrogens will be low, but the FSH and LH will be high. So this will be hypergonadotropic. So this is type 3. With regard to hypothalamic amenorrhea, it is reversible in many cases with lifestyle modification alone. Is it true or false?
True. True.
True. Yes, because there are no as such organic causes. These are mostly the other related conditions. So yes, absolutely correct. This is true. It is characterized by the high serum level of leptin.
False.
Yes, absolutely correct. This is false. Rather, the leptin levels are low. These are lean, thin patients. So leptin levels are low. Clomiphene citrate has been shown to successfully induce the ovulation in women with normal gonadotropins.
True.
True.
Yes, if you have normal gonadotropin levels, then clomiphene have a role. You can do that. Leptin therapy is not associated with any significant adverse effects. True or
True.
false?
True.
Yes, it's absolutely true. Correct. Yes, it's true. It does not have any significant adverse effects, but still, it is still in research. Till now, no such adverse effects are known. With regard to hypogonadotropic hypogonadism, most cases of Kallmann syndrome are associated with midline cranial syndrome.
True.
Yes. The Kallmann syndrome, there is anosmia, anosmia along with the midline cranial defects like the cleft palate, and simultaneously there is either renal agenesis also. So anosmia and hyposmia is a feature of the Kallmann syndrome.
True.
True. Yes, absolutely true. Then serum AMH level is a reliable predictor of ovarian reserve.
True. False.
False.
No, this is false. This is
False.
not
Why?
a reliable. Yeah, I'm telling you why. Because it has been shown that various studies have shown that the serum levels of AMH in women with hypogonadotropic hypogonadism, the results are lacking to show any this correlation between the AMH and the ovarian reserve, because these women may have either low, may have either normal or high. So this does not go with the correlate well with this. So there are basically, it is not a reliable predictor of the ovarian reserve in type 1 ovulation patients. So this will not be considered. Okay, so best clinical indicator for ovarian reserve is the ovarian response to stimulation with gonadotropins. So if you want to objectively demonstrate the ovarian reserve, then you have to stimulate the ovary with the gonadotropins, and that is the best option to do the objective prediction. The main drawback of the GnRH replacement treatment by comparison with gonadotropins for ovulation induction is multiple pregnancy.
False. False.
False, false.
Yes, this is false because GnRH has low chances of multiple pregnancy. It is the growth of follicle is monofollicular, so this is false. With regard to hypopituitarism, the most cases are transient and self-limiting.
False.
This is false because transient and self-limiting are mostly the hypothalamic amenorrhea, not the hypopituitarism. These are the causes which have affected the pituitary. So they are not transient and self-limiting. It is probably associated with increased risk of early pregnancy loss following conception with ovulation induction.
True. True.
Yes, this is true. In these patients, there is increased risk of early pregnancy loss following conception with ovulation induction. Pelvic ultrasound shows the multicystic ovaries with a large number of ventral follicles and minimal intervening stroma in most cases. True or false?
True. True.
No. In this case, there are small ovaries. If you go back to your chart, comparison chart, you can see here. Remember, this can be shown as multicystic. This is also multicystic, but this is small. So in this case, it is not there. Okay, the fertility treatment usually involves administration of gonadotropins for ovulation induction.
True. True.
Yes, because pituitary is not working, so you directly need the gonadotropins. GnRH cannot work here because the problem is at the level of pituitary. In relation to management of WHO type 1 on ovulation, HRT is associated with the maintenance of bone mineral density levels in the spine in women with prolonged amenorrhea.
True. True.
Yes, it is true because you need HRT for the bone health. Multidisciplinary management involves the counseling. Behavioral therapies should be considered in women with hypothalamic amenorrhea.
True.
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 Hypothalamic amenorrhea, this is true. The cognitive behavior therapy and lifestyle management is important component in cases of hypothalamic amenorrhea. Gonadotropin treatment is significantly more successful and has lower chances of multiple pregnancies by comparison with GnRH therapy.
False.
This is false. Again, same. GnRH is more successful. It has got more cumulative pregnancy rate and the monofollicular development, so low chances of multiple pregnancy. Cognitive behavior therapy does not have any proven value in management of women with hypothalamic amenorrhea presenting with subfertility.
False.
False. This has a role. CBT and lifestyle modifications have a role. With regard to physiological role of the hypothalamo-pituitary ovarian axis in female individuals, pulsatile secretion of GnRH from the hypothalamus varies in frequency throughout the menstrual cycle.
True.
True. Yes. The GnRH frequency varies. So, theca cells of the ovary lack the aromatase enzyme required to convert androgens to the estrogens.
True.
Yes, this is again true because here is the role of the two-cell theory. The granulosa cells have the aromatase enzyme and they will convert the androgens into the estrogen. So this finishes this today's talk article. Any questions? You are welcome.
Thank you, ma'am.
Okay.
Thank
So
you,
any
ma'am. We'll get
questions?
a recording, right?
Yeah. I'll post the recording in the group. Yeah, in a while.
Thank you.
Okay. Yeah, welcome.
Thank
So
you, doctor.
it finishes. Yes, it finishes an important CHOG article. You can go through it, and any questions you can leave in the group.